Hello, and welcome to another episode of AUA University Podcast, where we explore key topics that advance the practice of urology through expert insight and practical discussion. I'm your host, Dr. Mark Gonzalgo, professor of urology at the University of Miami and chair of the AUA's Office of Education. Today's episode focuses on a complex and fascinating topic, anorectal malformations, a spectrum of congenital anomalies that often require lifelong multidisciplinary care involving urology, colorectal surgery, and pediatrics. Joining me today are two outstanding experts in this field, Dr. Christina Ho and Dr. Molly Fuchs, who will share their insight on everything from diagnosis and surgical management to long-term outcomes. Dr. Christina Ho is co-director of GU Reconstruction at Children's National Colorectal Center, director of the Spina Bifida program, and assistant professor at George Washington University and Children's National Hospital in Washington, D.C. Dr. Molly Fuchs is chief of the Department of Pediatric Urology at Nationwide Children's Hospital in Columbus, Ohio. She is also urology director of the Myelomeningocele Clinic at Nationwide Children's and associate professor at the Ohio State University College of Medicine. Welcome to you both. It's great to have you here.
Thank you.
Thank you so much, Dr. Gonzalgo, and to AUA University.
So let's start with the basics. For our listeners who might not see these cases every day, what exactly are anorectal malformations and how common are they?
So anorectal malformations, they're a pretty broad spectrum of congenital anomalies that involve like abnormal development of the distal hindgut, anus, and rectum. Usually they occur in approximately 1 in 4,000 to 5,000 live births. With a slight male predominance in that. And, typically the hallmark is like an absent or ectopic anal opening that's often accompanied with an abnormal connection or what we consider a fistula to the urinary or the genital tract.
Thank you. And Dr. Fuchs, these anomalies can range widely from relatively simple defects to very complex cloacal malformations. Can you walk us through how these develop embryologically and what the spectrum of complexity looks like clinically?
Yeah, you're exactly right. I mean, to say someone has an imperforated anus or an anorectal malformation really doesn't give the whole picture because it is quite the spectrum of disease. So embryologically, this is an abnormality of the cloacal membrane, so essentially separating the rectum from the urinary tract, or in females, the rectum from the gynecologic and gastrointestinal, from the gynecologic and the urologic tract. This disruption can vary significantly. So you could have just a slight mislocation of the anus on the perineum, or the perineum can insert really low on the urinary tract, or even as high as up into the bladder. So just the absence of an anus really doesn't tell you how severe the abnormality is. But we do know that the more low on the urinary tract that the anus inserts, the less severe it's considered, and the higher up, the more severe and commonly more associated abnormalities you may see.
Now, as urologists, we're often brought in because these children frequently have associated GU anomalies. How strong is that correlation? What should we be screening for early on? And perhaps a quick word on vectoral associations.
I think going back to the embryology, because of that kind of shared origin, urologic anomalies are fairly common in patients with anorectal malformations. I think studies cite between 30 to 50% of cases, there can be urologic anomalies. These can range from vesicoureteral reflux to hydronephrosis or renal dysplasia, ectopic ureters, but can also involve, other anomalies of the GU tract, including like hypospadias. With reports of about like 5 to 20% of males with anorectal malformations also having hypospadias. Other associated anomalies can also be anomalies of the sacrum or the spinal cord. And in fact, those are two pretty specific kind of anatomic findings that we also evaluate for in all of our patients who have anorectal malformations. So taken kind of together with the complexity of the anorectal malformation, they can kind of help portend future continence rates. So we talk about that a lot when we talk about these children. And VACTERL is a syndrome that basically makes up of additional anomalies of which anorectal malformations can fall within. They include vertebral anomalies, anorectal anomalies, cardiac issues, tracheoesophageal fistulas, renal anomalies, and limb anomalies. And so all those can kind of come together in a genetic syndrome, of which anorectal malformations are part of. So there's a lot of screening that goes to see if these children also fall within that spectrum.
Yeah, so even from the start, it's clear that these patients really need a coordinated multidisciplinary approach for treatment.
For sure.
We want to talk a little bit now about initial evaluation and management and looking kind of at key findings on our patients. So what are those key findings on prenatal imaging that might suggest an anorectal malformation? And once a baby is born, what does that immediate postnatal evaluation look like?
Yeah, so the most common thing that you'll see prenatally is a dilated rectum or colon in these kids, particularly in the boys. In girls, girls with really low imperforated anus or anorectal malformation, you may have completely normal prenatal findings. But in girls with cloaca, it's not uncommon to see hydrocolpos. So while this is more common to be diagnosed prenatally nowadays, as opposed to decades ago, there are still some times where a baby can be born and there's no prenatal suspicion for anorectal malformation at all. Typically, the biggest thing you can do when a child is born is examine them, which all pediatricians do when the baby's born. But the telltale sign is a missing or mislocated anus. In a female with cloaca, you'd be looking for a single perineal orifice. Those are sort of the hallmarks of this diagnosis, but there's also other things that you may notice, such as a flattened bottom, an anal dimple. You may notice in a girl with cloacal malformation that they may look like they have ambiguous genitalia, which oftentimes they'll get labeled as DSD, but if they have cloaca, it's just atypical genitalia, not necessarily a DSD diagnosis. You may notice other abnormalities such as the Bacterial association, such as like limb abnormalities, and the things that we discussed earlier. But a really thorough examination right up front is really critical. We'll often do diagnostic screening as well, including an echo, again, with the cardiac anomalies that can be found, a spinal ultrasound to look for spinal cord abnormalities, an x-ray to look at the bones of their spine and their pelvis, as well as renal imaging to look for hydronephrosis and often hydrocolpos in females.
Okay. You both have significant experience with surgical management of this condition. How has surgical management evolved over the years, and what are the key technical or timing considerations for surgery?
I mean, a real softball question there.
Yeah, I know.
Jeez.
Well, I'll say for the majority of anorectal malformations, this is a multidisciplinary approach in which we are working very closely with the colorectal surgeons. And so depending on if there are any urologic considerations, the first surgery that is thought about is diversion, right? Through doing a colostomy, and typically that's within the first few days of life. Typically more definitive repair in the form of like the posterior sagittal anorectoplasty, which is done by our colorectal colleagues. That can take place anytime between 6 months to 12 months. But that's a good time where we often think about, like, if they do have, urologic associations, is there anything that we can do at that time also to optimize success, right, in their care? So for example, if they have a hypospadias, then we would consider repair at that time too. If we need to consider anything like management of their bladder in some kind of form, then we think about that too. We can perform cystoscopies to evaluate their urethra and their bladder as well. But typically the anorectoplasty part of that is removal of the fistula as well, which is inherent to the surgery that's done by our colorectal colleagues.
Yeah, probably one of the biggest advances in management of anorectal malformation in boys is probably the minimally invasive techniques that have been really popularized more recently. Again, these are typically managed by our colorectal colleagues or ped surgery colleagues. So oftentimes urologists are really not even involved in the majority of these operations, particularly in centers where a lot of these are performed. So even urethral fistulas are managed by our colorectal or ped surgery colleagues without our involvement. But a lot of these are done minimally invasive with laparoscopy. they've made quite a few advances as far as how to manage these. Where urologists get involved is primarily with cloacal malformations or really severe bladder neck or bladder fistulas and anorectal malformation.
It is still important to have urology involvement in some form for patients with anorectal malformations just because of that high association with these anomalies. And as I think we'll talk about later too, kind of screening and monitoring, for these patients throughout their childhood because of potential associations that we know about that can then portend to renal dysfunction. So
no, absolutely. I think urologists should be involved in the care of these patients 100% of the time. The technical aspects of the surgical repair sometimes we're not included in, which is just fine. But yeah, it's a really interesting, evolving field, particularly in multidisciplinary centers in their care for these kids.
Great. And this is the next topic is something that was briefly touched upon and shifting gears now to perhaps the most complex end of the spectrum, and that would be cloacal malformations. In terms of cloacal malformations, how often do you encounter these in terms of incidence or evaluation? How often should we expect them, and what are key findings that distinguish them?
Yeah, so these malformations are quite rare. In Dr. Ho's in my practice, we probably see a lot of these, but in general practice, you may see one or two in your whole career as a pediatric urologist. So we can estimate that only about 40 of these, plus or minus, are born in the United States every year. So really quite uncommon, and the majority of them are taken care of at a number of centers. The hallmark findings in these patients is a single perineal orifice, as I discussed earlier. And again, sometimes these kids can have abnormal appearing genitalia, so they can often get labeled as a disorder of sexual differentiation. They'll often have a very dilated abdomen, particularly when it's a severe type of cloacal malformation, so where the rectum, vagina, and urethra have a very high confluence, well above the perineum. Because oftentimes babies will be voiding up into their vagina and up into their bellies, essentially. So the urine, they get hydrocolpos, and urine refluxes up through the cervix and out the fallopian tubes. They can have urinary ascites, which can be really profound. So they can look quite dilated and distended. The primary goal in managing these patients as newborns is decompressing all of the three organs that are involved. So they need to have a diverting colostomy. If they have hydrocolpos, it needs to be drained. And if their bladder is dilated or they have hydrourinonephrosis, we need to ensure adequate urinary drainage. So in the first 24 hours, that's really kind of the most critical thing that you need to think about in these kids, certainly assuming that they're not septic and sick. Once they're stable, those are the priorities in managing these newborns.
And I was just going to make a distinction that anorectal malformations can occur in males and females, but cloacal malformations, where you really have just that single common channel, that single orifice that kind of unite the GI tract, urinary tract, and gynecologic tract, that only occurs in females.
It's a really important point. I don't think everyone always recognizes that.
And Dr. Fuchs, you mentioned a lot in terms of management of hydrocolpos, but for someone who may not see this as frequently as either you or Dr. Ho, can you just walk us kind of through, in a nutshell, those initial steps in management when there is a finding of hydrocolpos, or other findings that can impact the urinary tract?
Sure. There's a number of ways that you can drain hydrocolpos, or fluid in the vagina or the bladder. And I think that's an area that has evolved a little bit over time. I think traditionally a vaginostomy or a vaginostomy tube might be placed for this. In our center, we often will just put a catheter in. It's simple. Doesn't require sedation. And oftentimes, even if it doesn't go into the bladder, it may go into the vagina and drain the hydrocolpos. And that can be helpful in and of itself. If the baby's stable, you can also initiate intermittent catheterization. And again, even if it doesn't go into the bladder each time, as long as it's draining the hydrocolpos, that can be very helpful. The really key thing about any kind of management of draining hydrocolpos is that you document that it is adequate drainage. So sometimes you may put a catheter in and it'll drain the hydrocolpos, but these babies are so small that tube may actually be blocking the urethra. So while it's draining the hydrocolpos, it's not allowing the bladder to drain. So you really need to monitor these findings on ultrasound and make sure that the management that you've done is working. Sometimes you do intermittent catheterization and it's not adequate to drain hydrocolpos. So again, confirming that the intervention you've done has worked. There's also a lot of gynecologic abnormalities in these children that you may see. They may have a vaginal septum. They may have a duplicated vagina. So you could drain hydrocolpos and urine's coming out of it. But if you do an ultrasound, you may see they have another hemivagina that's not drained at all. So these are very complicated kids. You sort of learn to expect the unexpected with them, and really ensuring that every step of the way, you're confirming that what you're intending to do is actually being done, commonly with a lot of ultrasounds. Sometimes you can drain hydrocolpos initially one time with a catheterization, and it never recurs. It's pretty remarkable, actually. Other times you may have a baby that's born with massive hydrocolpos and they'll have really impressive hydroureter and you may be concerned that everything's obstructed. They're going to need surgical intervention for their blocked kidneys. And all you do is drain the hydrocolpos. And if you give them enough time, everything decompresses. So sort of a balance of a sense of urgency, but also patience and allowing the baby to sort of declare themselves on what they need, and giving each of your interventions time, I think, is an important point.
And, I think exactly as Dr. Fuchs said regarding hydrocolpos, that's the reason why we, especially in that initial postnatal period, think about it so much. It's because of the spectrum that it can lie on, where it can be very massive distension of the vagina, which hydrocolpos is basically distension of the vagina with fluid, which is urine. And that's because of the kind of the location of the vaginal confluence into the common channel and how that urine may preferentially drain into the vagina as opposed to out through the common channel. So, thinking about obstruction, that vagina being filled with fluid, obstructing the ureters, causing hydroureter nephrosis, potentially being a source for infection. Those are all things that we're trying to manage, especially as urologists in that immediate postnatal period. Very similarly, here in our institution, we do a similar kind of practice where we start typically just with catheterization if there is concern for hydrocolpos, especially in that setting of bilateral hydronephrosis where we're worried that that vaginal fluid is obstructing. Most of the time, I will say that's pretty successful in helping to drain the hydrocolpos. Rarely or sometimes we do have to, do either vaginostomies or potentially a vaginostomy tube or a vesicostomy. When we do that or think about that, we typically, consider that at the time of the colostomy and pair it with the colostomy.
Great. Thank you. Again, a lot of very important information there, especially early on. Switching gears now to the concept or finding, I should say, of urogenital separation and management of this condition. From a surgical standpoint, are there any guiding principles for reconstruction, particularly in terms of total urogenital mobilization versus urogenital separation?
Yeah, absolutely. I mean, I think the biggest finding and point to drive home is making sure you understand the anatomy that you're dealing with before you get into the operating room. And that's probably been one of the biggest shifts over the past 10 to 15 years with management of cloacal malformation. So it would be quite common decades ago where you would take a child to the operating room and you weren't quite sure which type of operation you were going to do. And there wasn't an emphasis on evaluating the measurements of the common channel and the urethra. But over the past 10 or 12 years, that's become really paramount in managing these kids. So we recommend whichever way you want to measure them, whether it be with cystoscopy or with cloacograms, 3D imaging, 2D imaging, it really doesn't much matter as long as you have a really good understanding of how long the common channel is and how long the urethra is. And that is really the guiding principle behind which procedure you're going to do. So a child with a long common channel is so greater than 3 centimeters in length is always going to get what's called a urogenital separation. And that's where you separate the vagina off of the common channel and pull it through down to the perineum. And then you then repair the area where the vagina entered into the urinary tract. You then leave the common channel, thereby as the urethra. Children with short common channels oftentimes can have what's called a total urogenital mobilization. So you mobilize the entire urogenital sinus and bring it down to the perineum. The caveat with that, though, is there's some kids that have a short common channel who also have a very short urethra. And this is something where I think urologists really added a lot to the conversation of repairs of cloacal malformation, because when general surgeons were doing this independently of urologists, they would say, oh, let's bring it down. It's no big deal. But if a child has a 0.5 centimeter urethra, you can imagine that they would have hardly any urethra at the perineum, and they'd likely be incontinent and at risk of urinary tract infections. So those with a short common channel, but a short urethra, we actually advocate for them to have what's called the urogenital separation. So actually leaving that common channel, even though it's very short, and separating the vagina off. And we think that's really important in determining the management and the surgical technique for the repair of cloacal malformations.
Now, some of our listeners may have heard about an ongoing debate regarding ideal timing and extent of reconstruction. Where do you both land on that question?
So I would say typically at our institution, we are doing kind of the definitive cloacal repairs between 6 to 12 months. Our median age, I think when we last looked through our database, was around 8 months of age is when we were doing them. And typically we have it set up where we do that diagnostic evaluation that Dr. Fuchs was talking about with an exam under anesthesia, cystoscopy, vaginoscopy, and the cloacogram, which we do as kind of like a 3D CT scan with contrast, where it kind of combines elements of like a distal colostogram plus a cystogram to get a better understanding of the anatomy and also define the lengths of the common channel versus urethral length versus where the vaginal confluence is, to kind of determine what reconstruction is best, and then plan for the reconstruction, the next day or very shortly thereafter.
Yeah, that's a really important point. I think there's a tendency to want to get problems solved. And I think families want to get problems fixed. But, some of these kids are quite sick when they're born. They're in the hospital for long periods of time.
For sure.
So as long as all of their organ systems are drained and they're doing well, I think there's no rush to do this operation. And so, we used to talk about doing it at 3 months, 4 months, but really there's no big rush. I think you leave them alone, you let them go home, you let them bond with their families, you get them eating and growing and getting some positive nitrogen balance in their bodies. And then they're really big and healthy and can tolerate a really big operation, and commonly 5 to 7 days in the hospital. So I think 9 months, we shoot for 6 to 12, similar to Dr. Ho's institution. 9 months is generally a really nice sweet spot. But again, if they've got other things going on, some of them have TE fistulas that they need to be repaired. Others have spinal cord abnormalities or tethered cords that they're getting managed. So if it gets pushed off later, I don't think that's a real big concern. But in general, we kind of talk about 6 to 12 months because kids aren't walking yet. They're big enough and healthy enough, but not quite mobile enough that they're going to cause problems with their surgical recovery. Another point I wanted to make is that there's oftentimes a real sense of urgency to understand the anatomy and figure out what's going on. And so some people will take newborns to the operating room for cystoscopies and evaluations of their anatomy. The reality, though, is these tissues are really delicate. And I think it's imperative that we as surgeons are cautious with thinking about the harm that we could do by putting kids through these evaluations. And I don't think there's any reason to take a kid as a newborn for a cystoscopy. I think you let them get a little bit bigger, let them grow a little bit more, and make sure that we can do our evaluations really safely. We've certainly all seen kids that have had cystoscopies early in life, in newborn, full-term or premature kids, where a scope can really cause a lot of harm. So I think as long as everything's drained, you just let them be and let them grow a little bit, and then get your information a little bit later.
Yeah, totally agree with that. I think, the tenets of just that initial postnatal period is stabilizing them, colostomy, maximizing drainage from a urinary standpoint, and managing hydrocolpos, and just helping them to grow and thrive and be healthy. And then that 6 to 12 month mark or 9-month mark, I think, is really a sweet spot that we found as well to kind of balance recovery with their growth to maximize surgery. So yeah, that's what we go for as well.
Great. Thank you both for your insight to that very practical question. Shifting gears now to the subject of long-term bladder management and renal protection. Once the initial reconstruction is done, we know these children remain under close urologic care for years, often into adulthood. How common is renal dysplasia or chronic kidney disease in this population, and what are the primary drivers?
So I think that, studies differ a little bit, but a lot have consistently shown that chronic kidney disease can affect, upwards of up to 50% of patients with really complex anorectal malformations or cloacal malformations. I think the general number is maybe 20 to 30% across all anorectal malformations. But keeping in mind that the more complex anorectal malformations are going to have a higher association with urologic anomalies too. And so, the most common reasons are going to be because of severe kind of upper tract anomalies. So high-grade hydroureteronephrosis, high-grade vesicoureteral reflux, solitary kidneys, potentially with ipsilateral anomalies as well. And then a lot of these patients potentially can develop voiding dysfunction later on or develop urinary tract infections that can kind of potentiate their renal disease as well. And then sometimes their intrinsic renal disease, is only unmasked with more growth later in childhood or in adolescence. So I think a lot of these scenarios need to be kind of anticipated and managed. And it emphasizes really that need for careful bladder management and renal surveillance protocols throughout childhood and into adulthood.
Yeah, I think that's a great point, Christina. When you look at historical studies looking at renal dysplasia, the outcomes are really startling. They've had reports of rates as high as 66 to even 100% of patients with CKD, and it's startling. Luckily, those, again, are more historical. And as urologists have become more involved and we've appreciated the complexities of cloacal malformation and multidisciplinary centers are more common now, luckily, we're seeing improved results. But when I meet a patient with cloacal malformation and their family, I tell them we're going to know each other your whole life because this is going to be something you're going to have to think about forever. And I think we have really encouraging data that we're able to keep the majority of kids safe. We looked at 10-year data at our institution and only 3% had CKD 3B or greater. But again, that's only 10 years and most of these kids are prepubertal. So what happens to them long-term is really unclear. We also think a lot about maybe not the majority, but a lot of these kids are not able to potty train typically. So they need assisted bladder emptying with intermittent catheterization. A number of them have augmentations and creation of catheterizable channels, sometimes even bladder neck procedures. So what are we doing that may be putting their kidneys at risk as well? So it's always a balance of the benefits of being continent, but also the risks that's doing to your kidneys. So careful counseling with families, discussing the risks of surgery, the risks of urinary tract infections, the risks of not being compliant with the bladder management recommendations that we've put in place for them, and just making sure that they understand that these kids have high rates of kidney disease, and we want to protect their kidneys at all costs.
When it comes to bladder management, how do you decide between encouraging volitional voiding versus initiating CIC or other forms of assisted bladder emptying?
Great question. One of the things we didn't mention before is I'll often get urodynamics in these kids, even in infancy, before we do their surgery. That's a bit controversial. Some people don't think that you can glean anything from those urodynamics, and I'm the first to admit they're not very good studies, but I feel like if I can get any information out of it, then it's worth it. And so we will always do urodynamics before and after cloacal repair at our hospital. Again, that is not what everyone does, but that's what we do. And we know that most kids with total urogenital mobilization have pretty healthy bladders afterwards. We don't think that we're causing a lot of problems by doing that operation, but urogenital separations make me really nervous. So I evaluate urodynamics 3 months after their surgery. And then I make a determination whether or not a kid can void volitionally at that point, or if they need intermittent catheterization. If they don't empty well, if they have UTIs, then I'll put them on catheterization. In fact, all of our patients at our hospital are started on catheterization after their initial repair, and then we wean it off. Those that are able to be weaned off, we then give them a chance to try to potty train. I tell them it's probably going to be later than you would expect for a girl without cloaca, but typically between 3 and 4, I tell them give it a try, but don't, beat yourself up if it's not working, because sometimes there's, anatomic reasons why they're unable to potty train. So oftentimes if they can't, we'll get a urodynamics at that point, and we'll determine whether or not they need intermittent catheterization, or if their bladder dynamics are such that they're just maybe won't be able to potty train. And then we talk about doing surgery later on to get them dry when they feel like they're ready, typically around age 5 to 6.
Yeah, I think that we are also probably equally aggressive or conservative, I don't know what the best word is, at being sure that we're evaluating the bladder appropriately and managing it to the best that we can, knowing that things may potentially change as these patients grow, and we're evaluating their bladders when they're still quite young, right? Like 6 months old or 12 months old. A lot of times we do not get baseline urodynamics. I think a big part of that is, meaning prior to the cloacal repair, I think a big part of that is just a lot of our patients come from, different parts, and they're not very close by locally. So that makes it difficult to kind of organize their itineraries to come. So when they're coming, they're really coming for their repair. But we do try to get urodynamics after cloacal repair, typically around 2 to 3 months afterwards. And then all of our patients get a suprapubic tube at the time of the cloacal repair. They go home with that. And then when they return, about a month to 2 months later for their colostomy closure, we start to do capping trials of the suprapubic tube, and then we can assess based on those capping trials in combination with ultrasound as well, to get a sense of if they're having any residual, urine that they're retaining. And if they have more than 30% of their estimated bladder capacity, then we start CIC at that time, and they go home with that, and then we'll repeat urodynamics about 3 to 6 months after that to continue to monitor things.
Thank you. So last question for this subject, just wanted really quickly, what does your long-term monitoring protocol look like, both from a urologic and renal standpoint?
Lots of ultrasounds and lots of labs, what I tell them. All of our kids get, at a minimum, annual ultrasounds and labs. So they get a basic metabolic panel and a cystatin C. And that is the absolute minimum any of them will get at our hospital. During the early period after cloacal repair, they might get ultrasounds more often than that. But sort of once they're stable and doing well and recovering, an annual ultrasound and labs. If they start getting infections or have any other concerns, certainly we may add on other testing, but that's sort of the absolute minimum that they get from us.
Dr. Ho?
Yeah, very similarly. Initially after the cloacal repair, we'll do an ultrasound anywhere from 3 to 6 months afterwards. And then we continue to monitor pretty closely because we found that about like 58% of our cloacal patients had CKD stage 2. And so we monitor pretty aggressively for any kind of progression and get nephrology involved pretty quickly as well. So we do, at the very minimum, an annual ultrasound and labs, like Dr. Fuchs was saying, but more commonly we're checking a little bit more regularly than that, probably about every 6 months or so.
I think another good point is that, I think most of these kids, if not all, should be hooked in with nephrology. I think that's a point that we didn't bring up earlier. But, a large portion compared to the general population is going to have a solitary kidney with cloacal malformation. I think it's around the order of 25% have one kidney. And, one kidney and all of these other urologic concerns, that can be a setup for renal failure. So we really want to make sure we're preserving their renal function. So I think being proactive and getting involved with nephrology is really, really important.
Great. I think there's such an important message. The reconstructive surgery is really just the beginning. The lifelong follow-up is really what determines renal and functional outcomes. And before we close, I'd love to touch briefly on two often under-discussed aspects, fertility and transition. So very briefly, because we're running short on time, but I think it's important to go over some of this for our audience. How do you counsel families and eventually patients on fertility and sexual function as they grow older?
An important part of our multidisciplinary clinic is our pediatric gynecologist. And especially for our girls with cloacal malformations, they play a very big role in kind of evaluating them when they go through puberty, managing any kind of issues that arise at that time from an anatomic standpoint, but also counseling them, on fertility as well. I would say from our gynecologists, I have learned that, depending on the level of their cloacal malformation, many of those females often achieve normal sexual function. And typically fertility, but it depends a lot on kind of if there's any uterine anomalies that go along with that. Although the recommendation is often to undergo C-section at time of birth for these patients. And then I think for our male patients, there are lots of studies that talk about concerns for sexual dysfunction, ejaculatory dysfunction, or potentially infertility that can be associated with anorectal malformations. I think this is still kind of being evaluated, but that's why it is so important for our patients to continue to be evaluated by urologists, even as they kind of grow up and in a sense grow out of the pediatric world, right? And continue to kind of be, followed into adulthood, that they understand what their urologic history has been like, and that they can continue to seek care with our partners who work in the transition world. So who are, potentially adult reconstructive urologists or even pediatric urologists who have a lot of experience dealing with young adults with this congenital history.
Thank you. And Dr. Fuchs, I just want to touch on the subject of transition of care. I think Dr. Ho just mentioned that briefly. Do you have any recommendations or strategies for effective transition from pediatric to adult urology, especially to maintain that continuity of care?
Yeah, I think one of the tenets of transition is assessing a patient's readiness to transition. So attempting to get a patient to transition before they are ready or able to, I think just results in failed transition. And none of us are in the business of kicking patients out of our hospitals. So we're very lucky in a number of ways at our hospital. One, that we can see patients of any age. And we don't, particularly in areas like our cloacal malformations, we will see them at any point at any time. That being said, oftentimes being in an adult hospital makes a lot more sense. So we're really lucky that we have an adult colorectal surgeon who's sort of dual trained in peds and adults. So most of our patients do transition to Ohio State if they're local, or even if they're not local, but they can see Dr. Geisher there. And we have two fantastic reconstruction urologists at Ohio State that are willing and able to see our patients there as well. Our multidisciplinary clinic is only 11 years old, so a lot of our patients haven't yet transitioned, at least not our cloacas. So I think the future remains to be a little bit we'll see what happens. I don't quite know. I can tell you that most of them like staying with us and want to stay with us, but it's really important that they transition, particularly, as Dr. Ho said, to a gynecologist who understands these potential risky gynecologic structures. One point I wanted to make that I think is really important is that girls with cloacal malformations are extremely likely to have vaginal and uterine abnormalities, but their ovaries are typically normal. And so their fertility potential is actually normal with respect to their ability to produce eggs. But their ability to carry a pregnancy or deliver a pregnancy is what is really unknown. And so I think that's important. And, we lean on our three amazing pediatric and adolescent gynecologists in this, and they're wonderful. But they do a lot of talking to these families about screening for obstructed gynecologic structures as they get older, and then talking about fertility and ability not only to have a child, but to carry a child. And I think that's where the transition is really so critical for these patients. And we're very lucky that we have amazing gynecologists that take care of these kids.
Well, great. Thank you, Dr. Ho, Dr. Fuchs. Thank you both for an incredibly insightful and engaging discussion. For our listeners, anorectal malformations represent a lifelong journey that highlights the best of multidisciplinary collaboration between pediatric surgery, urology, gynecology, nephrology, and beyond. I'm Dr. Mark Gonzalgo. Thank you for listening. And as always, stay curious, stay compassionate, and keep learning.